Welcome to the 10th and final talk in the neurology series. Thanks for hanging in there. So this one's on Alzheimer's. It's quite a good talk, I think. As always, we'll talk about a bit of history. Now, Alzheimer's is a process underlying a clinical syndrome of dementia. So dementia and Alzheimer's are not the same. Dementia is what you sort of see in a person. Alzheimer's is the process that underlies it. And for most of history, dementia has been seen as an inevitable result of aging, which is unfortunate. So 2,000 to 3,000 years ago, it was Pythagoras who described this thing called the senium. And this is where the word senile comes from, obviously. The senium was a period at the end of life that Pythagoras said was associated with a lost ability to reason. And this led to the concept of senile dementia, which were a constellation of symptoms that were seen as, according to Pythagoras, an inevitable result of aging. This lasted for most of history, and it was not until just over 100 years ago that Dr. Alzheimer, in 1910, described these, what were thought to be unique changes at the time in a lady who was about 50. And so she was said to have, she obviously was developing cognitive symptoms suggestive of early dementia, and he found these plaques and tangles, and so he called it pre-senile dementia. And this was seen as something different from senile dementia. So shortly after that, the pre-senile dementia was also called Alzheimer's disease in honor of his name. Now, it should be mentioned there was another doctor, Oscar Fischer, who that very same year in 1910 described, he actually did a case series of 16 patients, and he described the plaques in very good detail. Unfortunately, he did not describe the tangles, but also I guess there may have been other reasons his name never achieved the popular status that Dr. Alzheimer's did. So he actually looked at 16 patients, not just one. Alzheimer did a case report, so that case report was forevermore responsible for this disorder being named after him. Now, it was not until about 40 to 50 years ago, not even half a century, that the Alzheimer's definition was finally expanded to include older people. So people started to notice that the pathology, the plaques and tangles, were pretty much the same in older people as they were in these pre-senile dementia cases. And so the definition of Alzheimer's was expanded to include all these older people, and suddenly overnight, because of that change in definition, Alzheimer's became much more common. And now, it's the most common cause of dementia, and we now see it, most people see it as an underlying brain disorder that it is associated with aging, but is not an inevitable result of aging at all. I think that's important to remember, that this should not be normalized. It should not be seen as a normal thing to get dementia as one ages. So what is this process? Again, it's like Parkinson's and a lot of the other neurodegenerative disorders. Alzheimer's is characterized by neuron loss in the brain in a particular pattern. So select neurons in select brain regions die, and in Alzheimer's, it starts in the hippocampus, which is a seahorse-shaped structure in the middle of the brain that's responsible for, quite a lot for its size. Episodic memories and spatial navigation, to name two things, but it probably does a lot more than that. Anyways, it starts in that hippocampus, the blue structure, and then it's followed by the entorhinal cortex, which is part of the neocortex or cortex beside the hippocampus. Some people think it's allocortex, not neocortex, but that is a detail we don't need to worry about too much. And after that, it affects the rest of the neocortex, as shown in red. And the parts of the cortex that get affected first are typically the temporal regions, followed by the parietal, frontal, and occipital. So, it doesn't always go exactly in that order, but it's more or less like that. So you can see how it hits the hippocampus and neocortex hard, whereas Parkinson's tends to go for the basal ganglia pretty hard in the brainstem structures. So it's different. In both cases, though, neurons are dying in a slow manner, and we're not sure why, although I suspect the two processes are linked. So Alzheimer's is a process, that's really important, that produces neuron loss. There's 4 facts that I think it's worth taking from this talk. First, know about the amyloid beta plaques. So the plaques are found, as you can see there in the circle in red, outside of the neurons. And these are aggregates of proteins. We don't know why they're there. And a lot of people think they're causative of the Alzheimer's process. But again, they may just be an intermediate or some kind of response to the actual process. So the role is uncertain. And there are also neurofibrillary tangles. Those are inside the neurons. So the abnormal neurons are on the right there, and the normal ones are on the left. And the main component of them is tau, and same thing, the role is uncertain. Are they causative? Are they an intermediate? Are they a response? Nobody knows. I have my own ideas, however, I'm not going to talk too much about those today. I'm going to give you guys some more facts. A third fact is that some people call Alzheimer's type 3 diabetes. It's kind of like seen as a brain-specific form of diabetes for the reason that the brain is absolutely impaired in its insulin signaling. So, type 2 diabetes is sort of peripheral tissues, muscle, skeletal muscle mainly, and fat throughout the body. Those show insulin resistance or impaired insulin signaling. And in this case, it's the brain. So it sort of shows brain insulin deficiency and resistance specific to the brain. And so it's kind of a combination of type 1 and type 2 diabetes as well. So type 1 diabetes, of course, is insulin deficiency. Type 2 diabetes is insulin resistance. And in Alzheimer's, you've got both, as shown by the diagram there. You've got inadequate insulin outside the neuron, and also the neuron is resistant to insulin. So it's a double whammy selecting the brain. So this is a very well-known finding in Alzheimer's, and I think it's something that is good to know. And finally, most importantly, in my opinion, is the fact that Alzheimer's mitochondria in the most affected regions are grossly abnormal. The numbers are decreased, their complexes are damaged, they don't look right under the microscope. And complex 4 is hit particularly hard. In Parkinson's, it's complex 1. Other disorders, such as Huntington's, likes to go for complexes 2 and 3 more. Does that mean much? I'm not sure. But basically, the mitochondria are definitely abnormal. And not just in neurons, other parts of the body too. Okay, so that's a bit of history on Alzheimer's and thinking about what it is. How do you diagnose it? So this is, for the world's most common neurodegenerative disorder, in my opinion, a little dissatisfying. But basically, if a person has a cognitive problem, a complaint of some sort, it's generally best to exclude alternatives before you come on Alzheimer's. In a way, Alzheimer's is a positive diagnosis, but in a way, it's a diagnosis you arrive at after you make sure it's none of these other things. So it's a clinical diagnosis. The major alternatives to rule out are these ones. So mild cognitive impairment, or MCI, and that's often preceded by subjective cognitive impairment, or SCI. That's where the person feels that they're not thinking correctly, but nobody else can really tell. Mild cognitive impairment, very close people can tell, but most people can't tell. And then there are several dementia mimics. There's a whole bunch in here that I've grouped in this box, many of which have a reversible element. And then there's a group of non-Alzheimer's dementias, the so-called cousins of Alzheimer's, that one must consider, and of course Alzheimer's itself. Now Alzheimer's, the last clinical criteria, I haven't checked in the last year or two, but the last clinical criteria were revised in 2011, 10 years ago, and you have to meet the criteria for all-cause dementia, and then you have to meet the criteria for probable Alzheimer's. And even then, your sensitivity and specificity for the diagnosis is not 100%, but it's not bad. So MCI, mild cognitive impairment. This is defined as a decrease in cognition, any one of those things in brackets, one or more of them, that exceeds normal aging without a decline in daily function. So this person can still work pretty well, they can still function in social relationships pretty well, but they can tell there's a problem, and people very close to them can tell there's a problem. Now, if one has MCI, it may be a very early onset of the process that is Alzheimer's, but Actually, in many cases, it is not. So you must be very careful not to think of it as a definite preliminary stage to Alzheimer's. It may be in some people, but in many people it is not. It could be many of the things that produce it. And so given that statistic, nonetheless, it is absolute fact that it increases the risk of conversion to Alzheimer's compared to someone without MCI by tenfold. And the annual conversion rate, to give you that in perspective, of a cognitively normal person is only 1% to 2% to Alzheimer's. In MCI, it's about 10 to 12%. So remember, when you talk about relative increases, you also should look at it in absolute context, right? So 10 times is more likely to get Alzheimer's, but that raises you from 1% to 2% to 10 to 12%, more or less. So your odds are still not bad. For MCI, there's a different kind of set of criteria called the Peterson criteria, and this is basically them. So it's clinical, and there must be a subjective cognitive complaint. There must be objective cognitive impairment for age, some kind of test that has been able to be performed that shows there is a decline. The person has to have largely intact daily function, work, social relationships, and an absence of frank dementia. The Dementia Mimics. Now, these can present with a cognitive problem too, and there's a whole lot of them. The mimics only comprise 10% of all dementia cases in the West, more or less. So they don't constitute a whole lot of the dementia cases, but the important thing about them is that they're potentially reversible, so it's very important to diagnose them. Now, that being said, most of them are not really all that reversible. We do like to find them, but even when you find them, a lot of the times they are only partially reversible, and some may not be reversible at all. Depression and medications are, in my opinion, two of the most common and important to assess for, because these you can treat these to a very good extent, in my opinion. So the medications would be any sedatives, analgesics, anxiolytics, antipsychotics, anticholinergics. There's a lot there. So you can do a lot of good here, again, by that concept of deprescribing, perhaps, that I mentioned in the last talk, on the 9th talk of the series, which we need to combat polypharmacy very, very hard, in my opinion. But other things, organ disorders, thyroid, liver, and kidney, vitamin deficiencies, infections, particularly HIV and syphilis. Yes, syphilis is extremely uncommon as a etiology of dementia now. However, it used to be the most common in history for a long time. So it's worth checking, especially if you're a neurologist. You do not want to miss a case of neurosyphilis. And a brain lesion can present with a dementia like clinical presentation. So any of those things in the bracket there. The non-Alzheimer's dementias. Now, these are very interesting because think of these as similar to Alzheimer's. I think of them as cousins, as in the process is, they all involve neurons slowly dying, and it may be similar in that they all show mitochondrial dysfunction, for example. There may be energy issues. However, the pattern is different, so they all have their own sort of signature pattern or signature pathological process, and that to me is the main difference, and that results in different clinical features. So Alzheimer's goes for the hippocampus and neocortex, right? These other ones go for slightly different structures. Collectively, these comprise maybe up to a third of all dementia cases. The most common would be the vascular dementias, followed by Lewy body and frontotemporal dementias. There's another one called a mixed dementia, which is Alzheimer's plus vascular. It's actually pretty darn common as well. So I would say these are the four that one must absolutely think about. And they all present quite differently clinically. So the vascular dementia is ischemic etiology. Basically, you can think of it as multiple strokes, many of which may not be, resulting in a clinical event. And the decline is step by step. The Lewy body dementia is neurodegenerative, of course. It's not ischemic, and it involves Lewy bodies. It's kind of like Parkinson's, but it starts with the cortex first. Starts with cognition as an early thing rather than Parkinson's, which starts with a lot of other symptoms. And two of the hallmarks of this one are fluctuating alertness and visual hallucinations. And of course, there may be some Parkinsonism. Frontotemporal dementia is neurodegenerative. It involves The protein tau, person gets blunted emotions and disinhibition of their social conduct. And then the mixed dementia is a combination of Alzheimer's and vascular. So it's good to look for these different clinical symptoms and signs if you have a patient presenting with cognitive decline. Now, that being said, if it's none of all those things, then you may be looking at Alzheimer's. So the definition of Alzheimer's is a decrease in cognition, any of those things in the brackets, exceeding normal aging, plus a noticeable decline in daily function. The decline of function is key. And actually, if you talk to people with Alzheimer's or their family members, it's the decline of function that bothers them more than anything, as opposed to the actual decline of cognition. They don't matter. It doesn't matter them to so much if they can't think about things as well. But if they can't do things they used to do, that's really troublesome. Alzheimer's is probably about 2/3 of all dementia cases. It is increasing. It is doubling every 20 years. We're going to see more of it. And those criteria I mentioned to you are about 80 to 90% accurate. So they're good, but they're not infallible. So remember, you have to fulfill the criteria for all-cause dementia. The first two are the most important. So it interferes with the ability to work or do other usual activities, and it's a decline from previous functioning and performance. And then you have to meet the criteria for probable Alzheimer's as well. So it should be gradual, not stepwise, for example, not acute. And it occurs over months to years. It's very slow Alzheimer's. And there should be no features of one of the non-Alzheimer's dementias that we went through in the previous couple slides. Okay, so Alzheimer's is not that easy to diagnose, but here's a suggested approach. So a person comes in with a cognitive complaint, usually it's a memory problem, and they may have a decline in daily function, and it's very, very good to have someone else corroborate this, because obviously the person with the cognitive problem may not be given an entirely reliable history. Always exclude depression, and look for anxiety too. They're very common, even if the person has Alzheimer's, you may want to treat those as well. And look at their medications for polypharmacy and see if they have any of those things in the brackets. You can just try removing those things slowly to see if that helps the cognition. Focused examination. Usually you look at just sort of a basic neurological exam and maybe do a bit of stuff to look for Parkinsonism. Maybe there's a Lewy body dementia in there, but the exam is rather limited compared to other disorders. You can use assessment tools, so you probably should assess cognition, and in NZ we tend to use the Addenbrook's cognitive examination. There's a long version and a short version, so it depends how much time you have. You may want to assess function, and you may want to assess depression with a couple of other scales. There's 2 suggestions there. And lab tests, I do this as a once-off. So again, this is mainly to exclude mimics, just to be 100% sure. You might be surprised one day if a VDRL comes back positive, or you've got a vitamin B12 problem or something like that. Just do it as a once-off so that you don't miss a reversible dementia. And I do brain imaging on these people routinely. Obviously, you want to get at least a CT head, ideally an MRI brain, because that looks at the soft tissues much better. And this is to exclude things like vascular dementia, subdurals, tumors, normal pressure hydrocephalus, and so on. Now, treating Alzheimer's is a lot different now. I think there are a lot more options than people realize, certainly than I was taught when I went through med school. So there's, of course, caregiving, medications, exercise, dietary modification, and these things called multi-domain interventions, which are quite intriguing. Caregiving. Make no mistake, in Alzheimer's, and it's a sad testament to the state of our treatments today, the best treatment, the gold standard, is the caregiver. If that caregiver is functioning well, that's the best treatment for the person with Alzheimer's. So unfortunately, Alzheimer's is often much harder on caregivers and family members than it is on the patient. I see this all the time. And so caregivers are up to 50% of them, it's an incredible statistic, meet the criteria for depression, and they are prone to caregiver burden, which is a state of chronic stress. If caregiver burden is allowed to continue, this will lead to caregiver burnout, a state of exhaustion, where the person, they may even lose their empathy and seem to not care. It's not that they don't care, it's that they're completely burnt out. So this is something to always screen in any patient who has a cognitive element to their neurological disorder, not just Alzheimer's, but any of the mimics I mentioned, and other things like Huntington's and Parkinson's and so on. The caregiver may be under a lot of stress, and it's really critical to just fire a few questions at them and see how they're doing, because you may need to treat the caregiver as well. Okay, so medications. We do have some medications for Alzheimer's. Most of the medications that we use at the moment inhibit acetylcholinesterase, which degrades acetylcholine to maintain neurotransmitter levels. I'm not going to go into that in great detail how that works, but here's a slide of some of the drugs that have come out. Now, although there looks like there's a few there, 6 or 7, it's not a lot considering that this is spanning almost a 50-year period. Right? So our medications for Alzheimer's are really not satisfying at all. And in fact, a number of drug companies are walking away from Alzheimer's. It's in the too hard box. Anyways, what do we use? There are a few medications. To be honest, we probably use donepezil and rivastigmine by far the most here. Anyways, we don't really use galantamine or memantine. I have rarely ever seen it in a patient. And to put this in context, yes, they can help some people. They produce a 3-point improvement on a 70-point scale. It translates to a 4% clinical improvement at 6 months. And unfortunately, it lasts for sort of 6 to 18 months. So after a year or so, people are back to where they started. So it can help. Mind you, a lot of the times people get side effects and they can't tolerate the drug. So bradycardia, gastrointestinal upset, and so on can happen. And so you can see it's a bit of a stopgap, if anything, and it's not even a very good one, any of the medications. So the pros of medications, like all medications, are very easy to implement. You just write a script and off you go and start taking it. The cons are the improvement is slight and transient if it occurs at all, and there's a risk of adverse effects. Exercise. Exercise is a good therapy. It's generally classified as aerobic or resistance, and maybe it works by improving the mitochondria health, not sure. So aerobic exercise builds endurance by increasing heart rate and oxygen uptake. And you can do, a person with Alzheimer's can, they may be limited in what they can do. So walking, cycling, raking leaves, that's all fine. Resistance exercise is very good if the person can do it. So there are some examples of that. Most of the human evidence in Alzheimer's has looked at aerobic exercise. Now, there's a lot of studies on exercise in Alzheimer's, but I would say randomized controlled trials in cognitively normal elderly people show that exercise pretty reliably increases the hippocampal size by 1 to 2% after a year. That's not a lot, but hey, it's not bad. If you've got Alzheimer's and you're losing neurons at 1 to 2% a year, and then you're countering it with something that, that does that, then maybe that's a very good thing. So this is just a couple of figures showing the left hippocampus in the middle and the right hippocampus on the right end. What happened with the exercise group versus the non-exercising group at 6 and 12 months, and you can see the blue line is the exercise group. The volume of the hippocampus on both sides increased compared to the non-exercises where it actually slowly decreased. So that's countering the process at a very fundamental level, isn't it? So it's small but sure improvement. Okay, and there's other studies that are non-randomized. For example, this one is randomized. An RCT in 170 elderly people with memory problems. So they did not have Alzheimer's dementia. They just had a non-specific memory problem. And they showed that exercising for up to an hour 3 times a week resulted in a 1.5% improvement in cognition at 1 year compared to usual care. Again, a small change, but small but sure. And another RCT in 20 people with, this was advanced Alzheimer's. These people were getting cared for. Walking for a few minutes, 4 times, I'm not sure how many minutes there, it looks like I deleted the time. 4 times per week of walking anyways for a certain period of time resulted in a relatively mild 13% decline in cognition at 6 months compared to almost 50% in the control group. So you can see that the decline could be delayed by quite a bit. And what I'm trying to say here is if you look at the exercise evidence, I think the effects are not strong, but they are pretty definite. So The pros of exercise is it can delay hippocampal atrophy and increase hippocampal volume and cognition by maybe 1 to 2% per year. Exercise therefore produces a small but sure clinical improvement, and it may produce spin-off benefits. For example, reduced osteoporosis, muscle loss, so combats sarcopenia, and it definitely has beneficial effects on mood disorders, particularly depression, and very excellent antidepressant is exercise. Cons, it requires effort, right? So you've got a person that needs to actually get into a regular regimen. And of course, there's a chance of some injury or falls with the exercise itself, certainly at the start when a person is not conditioned yet. Diet. Now, dietary modification at the very simplest level, I wrote this talk a few years ago. At the time I said, the dietary modification is mainly modifying the macronutrient ratio, so fats, carbs, protein. I would now say that the most elemental aspect of dietary modification is changing meal frequency, not the macronutrient ratio, but we'll leave that there. And maybe this could be a very good thing for mitigating impaired insulin signaling and improving mitochondrial function. So again, diet is so misunderstood. And fasting, of course, is very misunderstood. They're so powerful mechanistically because they attack all these, they upregulate and or deregulate all these multi-targeted nutrient sensors. So insulin goes down on the right diet and fasting. And insulin, of course, stimulates cell growth in response to carbs. Mammalian target orexomycin gets stimulated in response to protein, so that will go down with these therapies. AMPK, AMP kinase, stimulates cell survival, energy conservation, and this beneficial process called autophagy, which is cell recycling, including mitochondria recycling. That goes up with the right diet and fasting. And PGC1 alpha, which is a mitochondria regulator that enhances mitochondrial function and so on, that goes up with fasting and the right diet, and the right diet being keto diet, but not only the keto diet. So if you just look at AMPK, for example, this truly is a master regulator of metabolism. It has spin-off effects, downstream effects on dozens, if not hundreds of other molecules. And so diet is potentially insanely powerful and really is completely unappreciated, in my opinion. So what's the evidence for dietary modification in Alzheimer's? Well, a lot of the evidence relates to low-fat, high-carb diets, and unfortunately, pretty much almost all of it is based on observational studies. So again, an observational study can detect a correlation, not causation, and we're more interested in causation. But there are 3 diets based on observational data that would be possibly better than other diets. Now, again, these are associated with people who get less Alzheimer's. It does not mean that the diet caused the reduction in Alzheimer's. It does not mean that at all. And one must always remember that. But anyways, the Japanese diet, health diet, which was made in a French study, and the Mediterranean diet are all 3 diets that have been correlated with less in dementia. Now, the Mediterranean diet, just be careful when that is defined, a lot of people mean a lot of things when they mean the Mediterranean diet. The fat to carbohydrate ratio can vary quite a lot. But generally, all 3 of these diets are lowish in fat, highish in carbohydrate. And it's not sugar carbohydrate. A lot of it's fiber-based, so vegetables you can see and fruit are prominent in all 3. And I would say beyond all of that, the true common denominator is they all involve real food. So real food, again, anything that does not have a label, does not need a label, is real. So think of chicken, steak, broccoli, carrots. Okay, keto diets. Now, interventional trials are very scarce. The first trial of the keto diet in Alzheimer's was done 4 years ago now by Taylor's group in the States. And this just looked at a keto diet in 15 people with Alzheimer's. And I'm focusing on keto diets here, obviously, but trust me, the interventional data for other diets is virtually non-existent. So anyway, Taylor's group looked at 15 people. They found that after 3 months, 11 people completed the protocol and improved their cognitive scores, just barely statistically significant, but it was there. Unfortunately, they did not have a control group, so they could not rule out contributing factors, namely the placebo effect. And they only looked at cognition. They didn't look at function, quality of life. So our group did a study 2 years ago, a randomized crossover trial, trying to build on Taylor's findings. And we examined a 12-week keto diet in 26 people with Alzheimer's. Now, a randomized crossover trial the design is such that if you do it properly, 26 patients is a lot of patients because there's much more statistical power can be demonstrated in a crossover trial compared to a normal RCT. Anyways, we had 21 people complete both arms of the trial, so 3 months keto, one diet, 10-week washout, 3 months the other diet. So everyone had both diets, and of course the competitor diet was their usual diet with low-fat, healthy eating guidelines supplemented in, what would be normally the standard of care dietary advice. And it quite clearly showed that there was a statistical and clinically meaningful significant improvement in both function, daily function, and quality of life. And those are two of our three main outcomes. We also looked at cognition. That did improve, but it did not meet statistical significance. There may have been a reason for that. But basically, it was quite encouraging, that second trial, because that was a crossover design, which is basically the most powerful you can get. And the patients on the keto diet improved their cardiovascular risk factors. HDL, triglycerides definitely improved. HbA1c improved. LDL, well, we're not going to talk about that because that's not as important a cardiac risk factor as the others. It's not a component of the metabolic syndrome, although people often focus on it for reasons we won't get into. Dietary modification. Anyhow, in theory, dietary modification can be very powerful, tackling Alzheimer's in a very multi-targeted manner by altering all those nutrient-sensing hormones and enzymes. And of course, it's the kind of thing it's hard to start. It's hard to do a lifestyle change, a dietary change, but it gets easier with time. Same with exercise, right? It gets easier with time. The cons of a diet is, you need to put some effort into it, particularly at the start. And most of the evidence, unfortunately, is observational. We need more interventional trials. Now, I'm going to finish this talk off with talking about the multi-domain interventions. There's a fair bit of interest about these too. Basically, this is any strategy that combines two or more of the previous interventions, plus others, to attack Alzheimer's from a number of different angles. So two of the most talked about, one's talked about a lot more than the other, but the lesser known one came from this study called the finger study. And the better known one is from Dr. Bredesen, who's a neurologist in the United States, who has this reversal of cognitive decline, or ReCODE multi-domain intervention that he has designed. So let's have a look at them. Now, the finger trial is based on a very large RCT that was done 7 years ago now, over 1,000 people. It did not examine Alzheimer's, unfortunately, but they looked at people at risk for cognitive impairment, so they did not even necessarily have cognitive impairment. But it was a 2-year study, and they were randomized to a group with 4 domains of intervention. So it was dietary modification, plus exercise, plus cognitive training, plus vascular risk factor modification, and a control group where none of those things occurred, but they just had general health advice. And you can see that there was quite an intensive intervention in the interventional group compared to the people getting regular health advice. Anyways, at the end of 2 years, there was a very slight improvement in cognition. Keep in mind, they had insanely huge numbers, over 1,000 patients, so any tiny difference is going to be statistically significant. It was not clinically meaningful, but the authors acknowledged that, at least, and so they said that this may not be a huge difference, but it could be meaningful in a public health context where a tiny change can make a big difference on a population level. So I guess my personal opinion is that's not too impressive. If a person can't really even tell that they've improved that much, how useful is it? But yeah, certainly on a population level, it would be helpful. So I don't think it was a bad thing. The pros and cons of finger trial, though. So the improvement was very slight. That was the pro. The cons, it looked at people at risk for cognitive impairment, not people with Alzheimer's. There was considerable effort. This is a lot of interventions, right? 4 interventions, not just one. And also, I think the cognitive improvements were a little underwhelming at the level of the individual patient, lacking in clinical significance. So is it worth all that effort to get that kind of result? I would suggest there's a better way. ReCODE. ReCODE is in some ways better than finger, I would think. I think. So Dr. Bredesen and his team have published several single-arm studies now of people with subjective cognitive impairment, mild cognitive impairment, and Alzheimer's. No RCTs to date. They're having trouble getting, I believe they're having trouble getting ethics for the RCT design. He wrote a book called The End of Alzheimer's. I've read it twice. It's a good book. I would just say it comes across very strongly. Whenever anyone claims to be able to end a condition that has been around for millennia, just consider that claim very carefully, is all I would say. Not saying it can't happen, just it's strongly worded. So he's done a number of studies every couple of years. He seems to come out with one. And I think there's another one that has just come out very recently as well. If not, it's going to come out very soon. So he looked at 10 people in each of the first two and then 100 in the 2018 study. And ReCODE is unique in that it's a very personalized thing. So the program varies from one person to the next. It's not the same intervention for each person. And so for one person, the program might target nutrient deprivation. So, the person has got a caloric excess or whatever, and so fasting might be a very powerful component. But for another person, it might be minimizing mold exposure. So his view of Alzheimer's is that it has a number of different etiologies, and that one must target that in the person exposed to that particular etiology. Now, ReCODE can be very, very lengthy and complicated. So here's an example from, I believe it was his first paper, of one of the patients. So this patient removed simple carbs, gluten, and processed foods, and increased vegetables, fruits, and non-farmed fish. They had yoga training and meditation 20 minutes twice a day. That's a lot of time. They increased their sleep from 4 to 5 to 7, 8 hours a night. Now, that's going to help a lot of people, isn't it? In addition, they put in melatonin, methylcobalamin, vitamin D, fish oil, coenzyme Q10, optimized oral hygiene with an electric toothbrush and floss, reinstituted hormone replacement therapy, and fasted 12 hours a day, including 3 hours before bedtime, and exercised 30 minutes 4 to 6 times a week. Now, that's not comprehensive. That's the list. Now, you can see how this is a wonderful lifestyle change. I'm not going to deny that. However, this is a full-time job, and you need to have a bit of cash to be able to do this. So, keep that in mind when you're looking at the outcomes. The outcomes some of them are very good. I don't deny it, but it is a lot of effort. So, in these earlier studies that he's published, after 1 or 2 years, most people had improved cognition, and some were quite impressive, with some people even returning to work. Now, again, the strongly worded thing, just think critically when you read things. I mean, I truly admire this protocol and what Dr. Bredesen's trying to do, but again, it's a bit strongly worded at times. So one exceptional case was mentioned where a man's hippocampus increased from the 17th to the 75th percentile. I would have preferred if they just used, that sounds huge, doesn't it? It sounds like it tripled in size or something, but it actually translates to sort of a 9% increase in volume. And remember, exercise therapies in multiple people, like groups of people, not just the single best person, show a sort of 1 to 2% increase in hippocampal size over a year as well. So this is great for that person, but of course this is the very best example that was demonstrated, and it's always good to consider that context. So ReCODE, pros. It tackles Alzheimer's in a massively multi-targeted manner. That's wonderful, and I think that's a very important thing. You have a very complex disorder, you're going to need a complex treatment approach. And there were some cognitive improvements in some people that were pretty good. Many of the participants that he looked at had SCI and MCI, not just Alzheimer's. So he's looked at a number of different things, and they're often mixed together. As I mentioned, there's major effort required to adhere to the interventions, not just time, but money as well. People can, they may need hundreds or even thousands of dollars per year to embark on this protocol. So one must have some cash as well as time. And again, my argument would be, well, if you did say 20 interventions and you had this amount of improvement, what if 80% of your improvement came from 20% of the interventions? Wouldn't you rather just want to focus on them? That would make it more feasible time and money-wise, and you'd still get almost the same benefits. So that, again, alludes to the Pareto principle, which is a general rule. I'm not sure if you know it, but sort of as an example, 80% of the output in any company or group or whatever usually comes from about 20% of the inputs. So you want to focus on those 20% if you want to maximize time and money in order to get the biggest bang for your buck. And this is a sort of a general rule. It doesn't apply to life in general. Pareto's law. Look it up if you haven't heard of it. And lastly, without a control group, these studies really, it's difficult to interpret them because the placebo effect was not controlled for, and the placebo effect can be extremely strong. You can get some amazing changes just from the placebo effect. So until we get a study with a control group, I'm not sure if we can recommend the ReCODE protocol really strongly, but you can still recommend it. So my treatment approach is this for Alzheimer's. As always, start with education. Tell the person about this disorder, and you may want to refer them to the local dementia community service. So in our case, it's Dementia Waikato. I discuss all the options if I have a patient there who I've made the diagnosis on. So medications, exercise, talk about diet, eliminate processed foods, eat real food. That's a no-brainer. Do they go on a keto diet or not? Well, I think it's reasonable to, the evidence is getting there with keto diets. It's reasonable to offer it, but only if a person is enthusiastic and interested, and I'm able to follow them up to a certain extent. I discuss the pros and cons of multi-domain interventions for people who look, who quite frankly have the time and money to be able to do them. And of course, always try to deprescribe. Introduce medication therapies as needed. So you can start with donepezil or rivastigmine. Treat a mood disorder, absolutely, if it's there and a problem, as you always would anyways. And crucially monitor and support that caregiver. That really, I think the first thing you do is to check in on the caregiver when you have these, husband and wife in the consult. Alzheimer's affects more women than men, so the caregiver may well be a husband, and see how they're doing. So monitor them for caregiver stress. Make sure home supports and community supports are all maximized. Make sure they're using their respite care every year, and monitor that caregiver for depression. Treat that if needed. And there are always people who want to do more. Actually, I find most people with Alzheimer's want to do more, and their family members certainly want to do more. So you can talk about a modified keto diet. I think that's reasonable now. Some GPs and specialists are familiar with ReCODE. I think that's very worth considering if the time and money, if the resources are there. And if you have any clinical trials on the go, definitely consider enrolling them in one of those. So to conclude this talk, the final talk in the series for the year, Alzheimer's is a pathological process that culminates in selective neuron loss in the hippocampus and neocortex. Diagnosis is clinical, and basically you have to exclude a number of possibilities, applying the 2011 McCann criteria for all-cause dementia and probable Alzheimer's. There are quite a few treatment options, and I would really go into this, and I fight against this idea that you've got no treatment options for a dementia process like Alzheimer's. We do have a lot. No, we're not there with a truly satisfying one yet, but we're going to keep working on it, and we're going to get there at some point in time. So we think about things like supporting the caregiver, medical therapies, exercise, consider dietary modification, multi-domain interventions. It's not an exhaustive list. I haven't talked about fasting and things like that, which, again, given that the talk was prepared some time ago, I probably need to update it. But I think we're going to see some real headway in Alzheimer's in the decades to come, and we need that because, as I said, it's doubling every 20 years. It's going to become a serious issue. All right, thank you very much.